Hello everyone. This course is a part of the project which is funded by the European Union and Russian Federation. The name of the project is Promotion of Breast and Colorectal Cancer Prevention Measures in Cross-Border Territories. The name of this course is Fight with Colorectal Cancer. My name is Dainius Šimčikas and I work in Day Surgery Center of Republican Klaipėda Hospital and also in Klaipėda University. In previous episode of this course, I talked about colorectal cancer, precancerous lesions, and now I would like to talk about colonoscopy performance measures. And we agreed that as endoscopists, we should use the endoscope as a spear to fight the precancerous lesions to prevent the cancer. Now I would like to share about how we improve performance measures in colonoscopy in our everyday practice. As a frame of this topic, I would like to use a beautiful guideline published in 2017 by European Society of Gastrointestinal Endoscopy. Authors of this guideline divided pericolonoscopy period into 7 domains, where each domain has one key performance measure and might have few minor performance measures. Key performance measures are rate of adequate bowel preparation, cecal intubation rate, adenoma detection rate, appropriate polypectomy technique, complication rate, patient experience, and appropriate post-polypectomy surveillance. Let's start from the pre-procedure domain, where everything starts from the consultation and looking for indications for colonoscopy. This is our day surgery center of Republican Klaipėda Hospital, where we provide ambulatory consultation service and day surgery service for hospitalized patients. The center is situated in the heart of Klaipėda, near the Marriage Palace. During consultation, we look for indications for colonoscopy and green corridor for the patient. Green corridor means if we highly suspect that patient might have colorectal cancer, we do our best that time to colonoscopy and computer tomography or MRI in rectal cancer case would be that this time would be as short as possible. Everything starts with anamnestic data from the patient's complaints. Sometimes they don't have complaints at all and they just come for the consultation because of positive immunochemical fecal or cold blood test. Very often patients come because of abdominal pain. Sometimes they come because the anal pain. Anal fissure is the most common reason for anal pain. Also, very commonly, patients come because they see the blood after the defecation. So I often ask them, do they see blood in stools coming from above, or they see just a blood on the paper, which usually suggests bleeding from hemorrhoids. Not very common complaint is abdominal mass. Usually they find hernia. Sometimes patients say that anal mass appeared recently. First of all, it was painful and then the pain disappeared. These symptoms suggest thrombosed hemorrhoids. Next, we collect the data about the history of the disease. As we ask how long do symptoms last. We ask about the whole defecation process from the feeling that the patient wants to defecate until the very end of the process. When patient says he has constipation or diarrhea, it is not enough to believe him. We need to ask exactly how many times per day or week does he defecate, and what type of stools does he have. For this purpose, we use Bristol's stool chart. It is very important to ask about previously done colonoscopies. Sometimes I consult the patient and look for the signs of possible cancer, and after some time he says that after 6 months ago he had colonoscopy. When we find out he had colonoscopy before, it is very important to have a written protocol of previous colonoscopy and histological data of biopsies taken before. And of course, family history is very important. About its importance, I talked in a previous episode. Further, we collect the anamnestic data about other diseases: diabetes, tuberculosis, bronchial asthma, jaundice, hepatitis B, C, HIV, previous myocardial infarction, coronary stents, coronary bypass operation, cardiostimulator, cerebral infarction, maybe colon diverticulitis. If the patient had those in red color marked events, most likely he is using antiplatelet drugs or anticoagulants. Colon diverticulitis is a very tricky disease, and it is always wise to start investigation from computer tomography. We also ask the patient about the all medication that he is using, especially about the usage of antiplatelet drugs and anticoagulants, which we usually recommend to discontinue before the colonoscopy. Previous operations is also a very important issue, especially operations in cavity of abdomen. Previous hysterectomies or the operations for peritonitis may suggest that patient might have adhesions in the abdomen, which might make colonoscopy a bit more difficult during the insertion of the colonoscope. All the anamnestic data that I mentioned, we put all together like a puzzle, and even before the physical education, we think whether there are indications for colonoscopy. And for example, if the patient comes and says, "You know, doctor, last few months something has changed. I have abdominal pain, it is crampy, and when it disappears when I pass the gas out." And patient says, "You know, my feces are strange, my stool is strange, it's like with blood, with mucus. And after defecation, after another 15 or 20 minutes, I want to defecate again." Plus, if the patient mentions that one or few his close relatives had colorectal cancer, in these situations, we should start thinking about the green corridor for the patient and perform colonoscopy not after a couple months, but after a couple weeks. Talking about physical examination, we should scan him right away at the same moment when patient enters the room. and we should classify the patient according to the American Society of Anesthesiologists Physical Status Scale, which says that class 1 patient is a normal healthy patient, class 2 a patient with mild systemic disease, class 3 patient with severe systemic disease, class 4 a patient with severe systemic disease that is a constant threat to life. Of course, in ambulatory service, we consult patients from class 1 to 3, but it's important to distinguish between class 2 and class 3 because according to general recommendations and also order of our health minister, day surgery services may be provided to patients with an SAA grade of anesthesia up to second class, and only in institutions providing resuscitation services too, day surgery services may be provided to patients with a degree of risk of anesthesia SAA score not exceeding class 3. So if the patient comes to your room and you can see he's suffocating, which means severe chronic pulmonary cardiopulmonary disease, maybe it's not a good idea to perform colonoscopy in ambulatory service. Next, after collecting the anamnestic data and scanning the patient according to SAAPS, we perform physical examination of the patient. We ask the patient to lie down on this table or bed and palpate the abdomen. If I palpate strange mass in colon projection and it's not coprolith, not abdominal muscle edge, but there are no acute symptoms, so palpated abdominal mass is an indication for colonoscopy through the green corridor, because I suspect it might be colorectal cancer. Also, at the same time, I refer the patient for chest, abdominal, and pelvic computed tomography scan with intravenous and transoral contrast. We warn the patient that he must have blood test for creatinine level because otherwise radiologists will not give him contrast. Of course, I perform also abdominal ultrasonography and I check whether the suspected mass looks like colon tumor or maybe it looks like coprolith. These findings and also partial ileus is an indication for colonoscopy through the green corridor. If I find liver mass, it is an indication for abdominal computed tomography. If liver mass looks like metastasis, it's an indication for chest, abdominal, and pelvic computed tomography with contrasts which I mentioned before. Also, findings like free fluid in abdominal or pelvic cavity of unclear origin is an indication for CT as well. The picture of ultrasonography and computer tomography. Next, we ask the patient turn on his left side and perform rectal digital examination. First, we inspect the skin around the anus, inspect the anus itself, and then palpate all the walls of the sphincter and of the rectum. If we palpate the rectal wall mass, it is an indication for the colonoscopy through the green corridor, pelvic MRI with intravenous contrast through the green corridor, and chest and abdominal computed tomography with intravenous and transoral contrast through the green corridor. Of course, we warn the patient again to have blood test for creatinine level and before the pelvic MRI to perform 2 microenemas. Even if I do not palpate the rectal wall mass, but when I pull the finger out and I see the blood on the end of the finger, it is no doubt that there is indication for colonoscopy. Next very important investigation method is erectoscopy, which we perform at the same ambulatory service if the rectum is prepared with microenemas. If we find a polyp, it is an indication for colonoscopy. If we find inflammation, it is indication for colonoscopy. If we see blood coming from above, it is indication for colonoscopy. There are worldwide accepted indications for colonoscopy, and of course they are stated in order of our health minister, and indications for colonoscopy are suspected colonic pathology following radiological examination, unclear cause of gastrointestinal bleeding, positive fecal occult blood test, unclear cause of anemia, unclear cause of chronic diarrhea, to confirm the diagnosis and spread of ulcerative colitis, to confirm the diagnosis of Crohn's disease, prolonged chronic low abdominal pain, chronic constipation, bloating, when a control colonoscopy is required if the intestine was prepared poorly for colonoscopy. There are more indications, and the last one is stating that colonoscopy is recommended for indications other than those if a colonoscopy is prescribed by a specialist doctor. And what does the mentioned guideline says about the indications for colonoscopy? It says that the colonic report should include an explicit indication for the procedure, categorized according to existing guidelines on appropriate use of colonoscopy, the ASGE or the EPAGE2 guidelines. The rationale for this statement is that colonoscopies with an appropriate indication are associated with higher diagnostic yield for relevant lesions than colonoscopies without an appropriate indication. And what are the standards? Minimum standard should be more than 85% and target standard is more than 95% of the cases. I would like to stop at one very important indication for colonoscopy, that is positive immunochemical fecal occult blood test. When there are no symptoms at all, it is recommended for persons over 45 years of age to perform this test annually. It is very important to inform the patient that he may do this test at home privately. He may buy it in pharmacy, read the instructions, defecate, make the solution of stool solution, and check it in the test for occult blood. The test is cheap, the test is non-invasive. Of course, you cannot trust the test 100%. That is why I recommend to perform it few times if the first test was negative. I highly recommend to perform the test when there is no bleed from anal region. I explain to the patient that the purpose of the test is to check whether the stools from above have blood inside. In this example, patient was very afraid to have the cancer, so she performed the test 4 times. 2 of them were negative and 2 of them were positive. So we performed the colonoscopy and found the polyp. I barely touched the head of the polyp with endoscope and it started bleeding. I removed the polyp and it was checked by pathologist under the microscope and the conclusion was inflammatory polyp. Luckily, inflammatory polyps are not precancerous lesions. The conclusions by the governments to perform IFOPT test for the patients starting at the age of 45. These conclusions arose from the fact that morbidity of colorectal cancer rises up in the graph from the age of 45. But I think because the test, IFOPT test, is cheap and non-invasive, we can recommend it to anybody. In my personal practice, I have met at least few patients with colorectal cancer between the age 20 and 30 who would wish they would be diagnosed with precancerous lesion rather than cancer. So if I find the indications for the colonoscopy, I explain to the patient what colonoscopy is and what we recommend for him to go through from the very beginning till the end. I explain that he will have to take blood tests before colonoscopy. Also, COVID test would be taken. That the patient will have to be on a diet before colonoscopy, to drink the bowel cleansing solution in certain regimen. I explained that after arrival there will be intravenous catheter placed in vein and that there will be an anesthesiologist who will give the medication through the catheter. I explained that the patient will fall asleep and I will insufflate the gas and insert the colonoscope into the to the colon. I explained that my job is to go through all the colon and to check it carefully. If I find anything like polyp, I might have to remove it. And after removal of the lesion, the percentage, even if it's so low, but there is a percentage of possible complications, like bleeding or perforation. I explain to every patient that perforation is a hole in colon and that such situation would require urgent operation and suturing the colon. I explained that most likely everything will be fine. After the procedure, patient will have to let the gas out, that the patient will be under supervision until he will become totally conscious, and that the same day we will let the patient go home. It is necessary to warn that after the sedation, patient will not be able to use any form of transport the same day. In the very end, I ask for the patient, does he or she agrees with everything what I said? If the answer is yes, we register the patient for the colonoscopy and explain again what he or she must do before the colonoscopy. After the explanation, we give all the details in written form as well. What tests should be done before colonoscopy? Not later than 2 weeks before colonoscopy, there should be performed the general blood test, blood clotting test, blood glucose levels if needed, electrocardiogram, and COVID-19 PCR test should be performed not later than 72 hours before the hospitalization or colonoscopy. If the patient is on antiplatelet or anticoagulant therapy, we recommend to use the medication or withdraw it according to the guidelines published by British Society of Gastroenterology and European Society of Gastrointestinal Endoscopy in 2016 and updated in 2021. And we act as it is recommended in the guidelines, where everything is beautifully described step by step. When to make interruption of the medication schedule and when to make resumption postoperatively. Let's move to another minor performance measure of the pre-procedure domain, which is time slot for colonoscopy. What do guidelines say? That time allotted for each colonoscopy in daily schedule is called time slot, and rationale for the statement is that colonoscopy needs adequate time allocated for the entire procedure, including discussion with the patient, sedation, insertion, withdrawal, and therapy. The pressure due to inadequate time slots may impair colonoscopy quality. What are the standards? Minimum standard is 30 minutes for clinical and primary screening colonoscopy, and colonoscopies following positive fecal or cold blood testing should be allocated a minimum of 45 minutes to allow for therapeutic intervention. It means we must plan our time to give the patient the best service possible. For example, if we perform colonoscopy and find one polyp of 15 millimeters and it is, for example, looks like adenoma with low-grade dysplasia and it is subpediculated, we should remove this polyp during the same procedure. My opinion is that taking biopsy only is not enough, and the excuse "I have no time for polycopectomy" is not the right choice. So that would be the end of this episode, and in next episode of this course I would like to talk about the pre-procedure domain's key performance measure, rate of adequate bowel preparation. Thank you very much for your attention.